All right. So the next speaker unfortunately couldn't be in person with us here today due to a prior commitment. So he pre-recorded his talk. So Dr. Edward Doyle is a neurotologist at the Cleveland Clinic who specializes in hearing restoration and vestibular schwannoma management. He's a part of the Neurofibromatosis Type 2 multidisciplinary care team. And as a part of this team, he works with patients to provide both surgical and non-surgical options to help patients' ability to hear and communicate. And so his talk is about managing hearing loss in neurofibromatosis and schwannomatosis.
Well, good morning. My name is Edward Doyle. I am one of the neurotologists here at Cleveland Clinic who helps with hearing rehabilitation in cases of neurofibromatosis type 2. So this morning we're going to be talking about a few things. Predominantly the question that I get a lot is, well, what can be done for my hearing at this stage? How do I improve my hearing with what I have? And it's a very nuanced and individualized approach for each and every single patient, and it depends upon where you are in this process. So I think the easiest way to break this thing down are practical considerations. What can you get? Hearing aids, bone conduction devices, a cochlear implant. Is an ABI an option? An auditory brainstem implant. So we're just going to go through a couple different things, and I actually have a couple videos in here that we're going to go through that kind of help explain some stuff and you can reference back to later. So I think that it's nice to understand how natural hearing mechanisms work, and this is a nice video that the company Cochlear, they make cochlear implants. They're out of Australia. They have put on about hearing, and we'll go to that right now.
How natural hearing works. The ear consists of three sections: the outer ear, the middle ear, and the inner ear. All three sections work together to deliver sound to the brain. In normal hearing, the outer ear picks up sound, which it sends in waves down the ear canal to the eardrum. These sound waves strike the eardrum and cause it to vibrate, sending the bones in the inner ear into motion. Fluid in the inner ear, or cochlea, then transfers this motion to tiny hair cells. The hair cells absorb the movement, creating electrical impulses which are sent to the brain via the hearing nerve. This translates into the sound you hear.
So that just explains the fundamentals of how we work to improve hearing, gives you a fundamental understanding of the mechanisms that we're going to be working with to try to improve a person's hearing. So what every person's journey begins with restoration of hearing is in the audiology booth. So we first have to diagnose what type of hearing loss and how bad the hearing loss really is. Is it a problem of just volume and not getting enough sound to where we need it to go? Or is it also a problem of clarity? Can you hear the words? You just can't really make it out and understand what a person is saying. And that's a fundamental difference that we have to be able to identify. So the first thing to think about that we can help with is giving somebody a hearing aid. You probably know many people with hearing aids. A hearing aid just makes sound louder. So it helps to amplify a sound signal that's coming in and uses the body's natural mechanism that's built already to help restore a person's ability to hear volume. So the steps to getting a hearing aid, as I said before, are first getting an audiogram. Most of the time, people with neurofibromatosis type 2 or vestibular schwannoma or any other type of hearing loss that affects usually one ear more than another or a different pattern of hearing loss between the two ears, they have to meet with an otologist just for a medical clearance and saying, okay, everything looks all right, you can go forward and get a hearing aid. There's nothing else we have to do. So that's a second meeting you have to have. And then you have to return to the audiologist for the fitting appointment for the hearing aid. Now, at that appointment, it's very important because they'll go through a bunch of different devices with you. And oftentimes, you'll select one and pay for it. But during that time afterwards, you have a 30-day trial. at any point during that time, you can get a full refund. And oftentimes that 30-day trial can be extended 45, 60 days, just depending upon working with a manufacturer. But I oftentimes tell people it's very important to wear the hearing aid every single day for at least 3 weeks. Wear it around, wear it at work, wear it in the car, because it takes your mind time to adapt to using that. There's many different types of devices. Traditional hearing aids, those devices are the ones that we just discussed, where they make the sound louder. There are other types of hearing aids that we'll discuss shortly. But basically, these hearing aids help to restore sound to both ears, and they make things louder so that people can be heard, words can be heard. But also the fundamental understanding you have to have is that they don't make things clear. The word recognition score, that's oftentimes something that you'll see or we'll talk about at appointments and visits. That's reported as a clarity score on the audiogram test. And the magic number is usually 60. People above 60%, they don't have as much of a garbled nature. People below 60%, I oftentimes explain that voices sound like the parents or the adults in the Charlie Brown cartoons, the wah, 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 wah. Nobody understands me. Like, I know you're saying something, but I can't really make out the words. And that's where we have to start thinking of different options, because all a hearing aid does in that situation is just make the sound louder, make that garbled nature louder. So another option for individuals who are struggling with one ear really being poor and the other being pretty good is a cross device. You may have heard of this before. This is what's called a contralateral routing of signal device. That's just a fancy way to say that it's taking sound from the good ear to the bad ear. And, from the bad ear to the good ear. And that's usually so that people don't have to turn their head all the time and be like, what'd you say? Or favor my good ear. The term bicross is used when there's hearing loss in the better hearing ear, and we need to also amplify the sound. So an easier way to represent that and to show that is this graphic here, in which sound stimulus going towards the poorer hearing ear, which is represented by the gray circle, and on each of these people, it's on the right side. So sound stimuli going to that side get taken up by a transmitter and sent to a receiver on the good side, on the good hearing ear. And that sound just gets played in. So it's basically like having a walkie-talkie, where it picks up sound from one side and goes to the other side, and it plays it there. The bicross also works as a hearing aid for the better hearing ear. I tell my patients that these are polarizing devices. Some people really, really like them, and some people really hate them. Because it's not just picking up sound, it's not just picking up all the noises you want to hear, it's picking up all the background noise as well. And that can be sometimes really challenging for people to use and to integrate into their life, because they think that sometimes it makes their natural hearing and their better hearing ear worse. So in my experience, the patients who do best with these types of devices are people with a particular goal in mind. I want to hear better at a meeting. I want to hear better when I'm working. I don't want to keep turning my head like this. But it takes a lot of practice. And I would strongly advise that anybody who goes through that really adhere to that refund period, because if you don't like it, you can always return it. To kind of stem off of that, another option for routing signal across the skull is a bone conduction hearing implant. So it's the same principle as before. You're routing the signal, routing the signal, and sending it through the skull. It involves a small and short surgery to be able to put a surgical screw into the skull and amplify sound off of that. So sound waves are now transmitted not electronically, but through the body's own natural mechanisms. So it goes from the right side here, where you can show, where we've shown a deaf cochlea, and the sound wave pictured in green here rotates across the top of the skull or through the skull and into the better functioning cochlea on the other side. So there's numerous studies in the audiology literature which show that sometimes these devices do better for people than cross devices or bicross devices. But again, if you were ever to consider doing something like this, I would have a long thought about the utility of the cross device first. And I would go through a cross trial before going through this. Again, we keep coming back to this principle that hearing aids will not impact the clarity of sound. They just make things louder, and if it's garbled to begin with, it's going to be more garbled and louder at the end. So that's where a cochlear implant comes into play. So just to emphasize and talk about the differences between the cochlear implant and a hearing aid, I broke this down into a table for you. So they're both devices that help you hear. Cochlear implants don't make sound normal, okay? Just like a hearing aid. A hearing aid doesn't really sound natural to some. A cochlear implant is going to be very different from using a hearing aid and very different from your natural hearing. I explain to people that the pitch can sometimes be off. People can sound like Darth Vader or Mickey Mouse or Minnie Mouse, and that can be hard for people to learn to live with after getting a cochlear implant. It requires a lot of practice until that gets better. Cochlear implantation requires a surgery, whereas a hearing aid doesn't. Cochlear implantation surgery is an outpatient procedure that typically lasts about 2 to 2.5 hours. And the cochlear implant has two parts. A sound processor worn on the outside of the head. It's a magnet that attaches to the internal device, which sits underneath the skin. Nothing is exposed, nothing is extending through the skin, but that attachment, that magnetic attachment, is important for the device to function. And then, of course, the hearing aids, they could either be worn inside the ear canal and hidden, or behind the ear. And the behind the ear technology has really improved to the point where you almost can't tell that somebody's wearing them when they have them in place anymore. So to further discuss cochlear implantation, again, what we were talking about before with the speech understanding. So that score, I said that people above 60% in general will do better with a hearing aid. Well, people with a score less than 60%, these are patients that we're targeting for cochlear implantation. So when a patient drops below that score, we oftentimes send them for additional testing, which would be cochlear implant evaluation. And that testing requires an individual to wear their hearing aids or wear hearing aids supplied by the clinic and go through a battery of tests to find out how are you functioning with the hearing aids in place. If you're functioning pretty well, then we would not consider cochlear implantation because cochlear implantation is imperfect. It's not going to restore sound past a certain level or past a certain amount of function. And following that, then we consider all of the other things I've listed as far as suitability to move forward with a surgical procedure, particularly among patients with neurofibromatosis type 2. In these patients, we oftentimes have a tumor that we're monitoring, and we have to make sure that there's been stability. So it used to be thought that if you have a tumor, you are not eligible to get a cochlear implant. Well, within the last couple decades, a growing body of literature has showed that it is, one, feasible. We're able to monitor tumor progression. We're able to safely perform an MRI with a cochlear implant in place. But also, cochlear implants enable people to have better speech perception and better ability to communicate with others, even though they have a tumor. So patients who are being observed or patients who have had their tumor radiated, those are excellent candidates to move forward, provided that the tumor has shown evidence of stability. Lastly, some patients who've undergone surgery can be eligible for a cochlear implant, but we have to make sure the cochlear nerve, the nerve that connects cochlea to the brain, is still intact and still functioning, because in certain individuals that doesn't, and the cochlear implant wouldn't work in those situations. So for these patients who have made it through each of these steps in the process and made sure that we're appropriately considering all outcomes, but also the feasibility of surgery for them, we could potentially move forward with a cochlear implant. So I have a little video just to explain and show how a cochlear implant works.
How the cochlear nucleus Canzo implant system works. The Nucleus Canzo implant system is designed to provide you access to the sound you're missing. Sound travels to your ear and the sound processor, which sits off the ear. The microphones on the sound processor pick up sounds, and the processor converts them into digital information. This information is transferred to the implant just under the skin. The implant sends digital sound signals down the electrode into the cochlea. The hearing nerve fibers in the cochlea pick up the signals and send them to the brain, which is translated as the sound you hear. Unlike a hearing aid that simply amplifies sound, cochlear implants send sound directly to the hearing nerve and on to the brain.
Okay, so just to recap on cochlear implants, the important considerations to understand is they're not perfect. It requires intense practice and daily use to regain some type of speech perception and understanding, and it's an outpatient surgery that has to be performed. Finally, something just to briefly discuss is an auditory brainstem implant. So this device would be considered among patients whose cochlear nerve function is no longer present. So patients who have undergone surgery, or we think that there's been some type of damage along the course of any type of treatment where the cochlear nerve wouldn't be functioning anymore. And typically these are patients who have undergone surgery on both ears who'd be getting a cochlear implant. Who'd be getting an auditory brainstem implant. The factors, the device is not inserted, the device that's inserted into the cochlea to help stimulate the cochlear nerve can't be done anymore. So we have to put something into that area of the brain that receives those neural inputs or the nerve fibers that come from the cochlea. And that's oftentimes difficult to place that exactly where it needs to go. So in these patients, the outcome as far as speech performance isn't as robust as a cochlear implant. All we're looking for sometimes is sound awareness or the enhanced ability to lip read. It's very unlikely that somebody who got an auditory brainstem implant would be able to understand speech in full conversations or speak on the telephone, whereas somebody with a cochlear implant would be able to do that. What's important to understand about this is not an outpatient surgical procedure. This would be an inpatient neurosurgical procedure with the ear, nose, and throat and neurosurgery teams working jointly. So to wrap up everything, we've talked about hearing aids, we've talked about bone conduction devices, we've talked about cochlear implantation and auditory brainstem implantation. Each of these technologies can help different people in different parts of the process as far as hearing is concerned, and depending upon where you are in the treatment phase or observation phase, any and all of these may be an option for you. So without further ado, thank you so much, and I hope you have a good rest of your day. Thank you.